Hello everyone, I am Dr. Prateek Joshi. This patient had twisting injury to his right knee joint after fall from a two-wheeler, and he had pain, swelling and instability in his right knee joint afterwards. On MRI and clinical examination, he was found to be having ACL tear. Anterior cruciate ligament is one of the commonest ligament injured after twisting injury of the knee, and here today we are going to do arthroscopic ACL reconstruction surgery. We have introduced our arthroscope through anterolateral portal, and I have inserted the femoral femur through the anteromedial portal. I am drilling the guide wire through the femoral femur while keeping the knee in hyperflexed position, and you are seeing that I am drilling the guide wire through the lateral femoral condyle in the native ACL footprint. Here we are drilling the guide wire in the lateral femoral condyle via accessory medial portal, which is going to help us in creating anatomical oblique ACL tunnels. Many years back, ACL reconstruction was being done by transtibial technique, in which the femoral tunnel was drilled through the tibial tunnel. So essentially both tibial and femoral tunnel were in one line. Disadvantage of this technique used to be reduced rotational stability many times and non-anatomical ACL tunnel placement sometimes. So as you can see, we have drilled the guide wire through the lateral femoral condyle in the ACL footprint, and now I am going to remove the femoral femur, and now I am going to drill with 4.5 mm endoverton drill bit over the guide wire. The laser markings over the endoverton drill bit gives us rough estimate about the length of our femoral tunnel. So in this case, we are feeling the resistance of the lateral femoral cortex at around 35 mm. So we are anticipating the length of the tunnel might be around 40 mm. So now we have completed the drilling of the lateral femoral condyle with the endoverton drill bit over the guide wire. We have removed the endoverton drill bit as well as the guide wire. Now I am going to insert the depth gauge to measure the depth of our femoral tunnel. So as you can see, the length of our femoral tunnel is 38 mm. So now again we are going to insert the guide wire in the same track, and now we are going to drill our femoral tunnel based on the diameter of our ACL graft, which we have already prepared. So here I am going to use 20 mm continuous loop endoverton so that we have 18 mm of graft inside the femoral tunnel. So in this case I am going to drill 18 plus 10, that is 28 mm, so that we have adequate distance for our button to flip. Our graft diameter is 9 mm, so we are going to make our tibial tunnel slightly posterior so that we don't have graft impingement, which might be a problem when we are using a 9 mm graft. The ideal footprint is just posterior and medial to the anterior horn of the lateral meniscus. So as you can see, the tip of our guide wire is in anatomical position, and now I am going to drill over this guide wire in a sequential manner, starting with 6 mm drill and then going to 9 mm drill. We had adjusted the angle in our ACL tibial jig at 55 degrees, and we had kept our ACL jig to around 20 degrees medially. So we have prepared our graft over the 20 mm continuous loop endoverton, and now as you are seeing, we are pulling the graft through the tibial and femoral tunnel. Shortly you will see the endoverton passing from the tibial tunnel and going to the femoral tunnel. There are two sets of threads available on the endoverton. One set of thread is to pull the graft with the button through the tibial and femoral tunnel, and other set of thread is to flip the endoverton as it crosses the lateral femoral cortex. So you can clearly see the continuous loop attached to the endoverton and the graft attached to the continuous loop, and now we are pulling our graft inside the femoral tunnel, and once we cross the mark of 18 mm of graft inside the femoral tunnel, we are going to flip our button by pulling the flipping thread attached to the endoverton. This is going to flip our endoverton over the lateral femoral cortex, and once it's flipped, we won't be able to pull the graft back down inside the tibial tunnel and outside of the knee joint. After this step, we cycle the knee to tension our graft throughout the range of motion, and then we fix the graft at the tibial end with the help of interference screw while keeping the knee in 30 degree of flexion and giving the posterior force over the proximal tibia while tightening the screw. This is the final picture of our graft as seen through the anterolateral portal. You can see it is in the anatomical position. It has good tension. This is going to give good rotational stability as well as the anteroposterior stability to this patient's knee joint. This completes the procedure. Thanks for watching this video.